Hi, my name is Francisca Ling. I am the chair for this year's Family Conference Planning Committee. I got it right. Thank you. Thank you. It is my pleasure to introduce our next speaker, Dr. Randall White. Dr. White is the medical director of BC Psychosis Program and clinical associate professor of psychiatry, at UBC. So please, let's welcome Dr. Randall White.
Thanks, Francisca. It's great to be here. Great to see such a group assembled. It's inspiring, I think, to us clinicians to know that a lot of you want to know more so that you're better equipped to help the people that you care about. So the program that I'm involved in is at UBC Hospital. It's a provincial program for clinical care, research, and education in schizophrenia and psychotic disorders, specifically what we call treatment-resistant illness. Now, I want to emphasize that it's not the patient or the client who's resistant to treatment, it's the disease. So it can sound like sort of a stigmatizing phrase, but if I lapse into saying someone's treatment resistant, I mean the disease, not the person. These are just some brief disclosures for some honoraria I have received. I do reviews for the province for new treatments to determine which medications may come on formulary. I've received an honorarium from a group in Washington that advocates for single-payer health care, and I've received an honorarium from Otsuka Lundbeck, a pharmaceutical company. So let me explain this concept of treatment resistance. Or maybe treatment response. So when we talk about people with severe persistent mental illness, there are a certain number who don't get better despite our best efforts and treatment with medications. And this is a reflection of the inadequacy of our current treatments. So I'll talk about this, and then I'll talk about some new treatments that are on the horizon and which may offer hope to you and the people you care about. So about 70 to 80% of people with psychosis that we treat with a medication will have improvement. We call that antipsychotic responsive schizophrenia or schizoaffective disorder. And I'll talk about the definition of response in a minute. Basically, though, it's the positive symptoms that we're treating. We don't really have good treatments for negative symptoms and cognitive impairments, the things that Dr. Fredrickson was talking about. Now, that leaves about 20 or 30% of people who don't get better with the usual kind of antipsychotics. Those are the people that we often end up treating with Clozapine. And it's a special medication that we keep in reserve because it has a lot of side effects. It's not easy for people to be on this medicine. It's hard for doctors to prescribe it, but it can be very effective. But again, anywhere from 40 to even 70% in some studies of people treated with Clozapine don't get better. They don't have what we call an adequate response. And so that kind of disease we call Clozapine resistant. And that could be up to 20% of all people with schizophrenia or schizoaffective disorder. So our program is dedicated to people with this kind of severe persistent illness. These are our admission criteria. So inadequate response of positive symptoms to 2 adequate trials of antipsychotics. And by response, in general, in the studies that are done, that means a 20% reduction in certain scores reflecting positive symptoms. It's not a huge reduction, actually, but if there's at least a 20% reduction, then that could be considered a treatment response. It's not recovery, don't get me wrong. And what is an adequate trial of an antipsychotic? Anywhere from 6 to 8 weeks at the maximally tolerated dose. That's kind of what we look at as being an adequate antipsychotic trial. So for clozapine, we usually try to give it at least 8 weeks, sometimes 12 weeks. But again, maybe around half of people aren't going to get that much better, even with clozapine. And so this group of patients, these people with this severe kind of illness, don't have a lot of alternatives right now, unfortunately. But I'll talk about efforts that we're undertaking and others to try to target this severe disease. There's certain terms you see in scientific research related to these patients. We call it clozapine resistance. You might see these other terms that I think are somewhat stigmatizing, ultra-resistant, et cetera. And then I want to mention there's a group I call the orphan patients, because they can't take clozapine because of severe side effects, because it causes, for instance, their white blood cell count to drop to dangerous levels. And everyone on clozapine has to have a regular blood test to make sure that doesn't happen. Or they have severe weight gain or severe sedation. As I said, it's not an easy medication to take. So that orphan group, they have resistant illness, but they can't even take clozapine. And there's not enough known about this group or what to do for them. So I'll just mention that, but I can't spend too much time on it right now. So I did a little calculation just to give a sense of how many people in BC we might have with this severe form of psychosis. So if we consider that about 8 out of 1,000 people have a psychotic disorder, and up to 20% have clozapine-resistant disease, then that means anywhere from 3,000 to almost 8,000 people could be living with clozapine-resistant schizophrenia in BC. And our program is part of the solution for helping this population, but we can't do it by ourselves. We have 25 beds. Our mean length of stay is 25 weeks because it takes quite a bit of time to properly diagnose and then do some attempts at treatment for people with this illness. So we can treat about 50 people per year. If we tried to treat everybody, it would take us maybe even 150 years. So part of my efforts are not only to treat the people that we can accommodate, but also to try to educate other people, psychiatrists and other clinicians, about this disorder and what the best approach might be. So I'm going to now talk about something that might be a bit scary to some of you and to the people the patients or the clients who might need help with this disorder, and that's electroconvulsive therapy. So ECT is a disorder, rather a treatment for a number of severe mental disorders, including depression sometimes, but also schizophrenia. And it is a powerful treatment. It, of course, has been portrayed in the media or in cinema and literature as being a punishment and not a treatment. But in appropriately selected patients, it can be very effective. It's done very safely. Patients are under general anesthesia when they get electroconvulsive therapy. It's not, it's not without side effects, especially sometimes effects on memory, which can be troubling to patients. But as far as treating clozapine-resistant disease, it's probably the most powerful treatment that we have at this point. Now, the amount of research done on this is not huge, but we have to go on what evidence exists out there. So there are 5 studies on this severe form of psychosis. One of them was published just last year. It was done at Harvard. It was a randomized single masked trial, which means that the people who rated the patients after their treatment did not know whether they had received the treatment or not. It was a high-quality trial, and in that trial, about half of the patients got better. And in general, the ECT given in these situations is bilateral, which means that the electrical stimulus is on both sides of the scalp. Some treatments, especially for depression, are given on one side. That can reduce the memory effects, but it's probably not effective enough for treating this kind of disorder. The adverse effects that were seen when you pool all the patients in these 5 clinical trials include, in a few cases, prolonged seizures. And a seizure is what we're looking for with ECT. We actually create a controlled seizure. The patient, as I said, is anesthetized, partially paralyzed. You don't see the movements of a seizure, but we see it in the brain tracing that we monitor. If a person has a seizure that doesn't stop by itself, we can give a medication IV. The anesthesiologist gives it IV, and it stops the seizure. Occasionally, some people will have confusion after ECT. In the studies, there was one person who had this repeatedly, but they were on lithium, and we know lithium is a side effect or can increase this side effect. So we try to avoid lithium when we're going to give this treatment. And then 2 of the people had sort of persistent memory problems. But the good news is that most of them did not have persistent memory problems. Most people who have the treatment will not remember a lot of what was going on during the course of the treatment, but it doesn't erase the memories of their childhood. It doesn't prevent them from learning new things later. Now, the fly in the ointment is that in one study, when they followed patients for a year, half of them relapsed. So we find that in this patient population, they often need maintenance treatment. In other words, they may have to go back twice a month or so to get a treatment to maintain their remission from the disease. All right, so ECT is an option, and it may be the best option for some people, but a lot of people don't want ECT, no matter how well I explain it to them the way I've explained it to you. We have an instructional video we show the patients, and families can see it. Anyway, some people don't want it, and we have to accept that. So what are some other options? What about cognitive behavior therapy, which is an evolving treatment for psychosis? There aren't a lot of studies in people with clozapine resistance, but in treatment-resistant psychosis, there are a number of studies, and actually this group who did this meta-analysis, which means an analysis of a lot of studies all put together, this group is from BC, they found that there was an effect, better than, quote, treatment as usual. So cognitive behavior therapy can be helpful for managing again, I want to emphasize positive symptoms, not so much the negative symptoms of this of treatment-resistant schizophrenia. We find one of the barriers, though, for cognitive behavior therapy is the negative symptoms, the lack of motivation. So getting people to be willing to go to a group or go to a series of appointments for this kind of treatment, that can be a challenge. And then there's another kind of neurostimulation or brain stimulation using electricity that I'll mention, because we hope to be getting a trial underway in our unit out at UBC. So it's called transcranial direct current stimulation, and this stimulation does not require anesthesia. You can be awake and doing other things while you're receiving it. It's painless. You might have a little tingling on the scalp. And it could be an option for people who don't want ECT. It also may be more effective for persistent auditory hallucinations or voices. So we're hoping to do a research protocol in the clozapine-resistant population here at UBC, as well as at Hillside Hospital in Kamloops. And it involves giving this treatment twice a day, 20 minutes or so per session. And I'm working with Drs. Fidel Vila and Carmen Molgat, hopefully to get this trial underway maybe early next year. So this is an algorithm we've created for managing this kind of illness, and we're trying to put this into practice and see how it works. I won't dwell on all the details here because it's a bit technical, but I just wanted to show that we are trying to improve the understanding and approach to managing the severe form of psychosis. And next, I'm going to switch into talking about new treatments, treatments that are under development, that are getting researched. And I'll go through a bit of a laundry list, but I hope you'll find it interesting, and maybe it will give you a bit of hope that the person in your life who isn't getting better on what we have now might have a new treatment coming down the pike. So these are two new medications that have been approved by the US FDA and might be on the Canadian market in the near term. So the first one is called brexpiprazole. It goes by this trade name Rexulti. It was approved last July by the US FDA for treatment of schizophrenia and for major depression. And it's been studied both for acute treatment, when somebody has an onset of schizophrenia, a recurrence or a first episode, but also for relapse prevention. It was studied over a year's time in groups of patients, and it was shown to reduce relapses. So it can be used for acute and maintenance treatment, in other words. It's similar to a medicine you might be familiar with called aripiprazole or Abilify. It's also being looked at for treating behavioral problems and psychosis related to dementia. And in fact, one site for this trial is in Penticton. It's kind of interesting to note. And I just found out that it is in fact under review by Health Canada for the indication of schizophrenia. So once Health Canada starts looking at a drug, it could be approved within a year, and then it would go through another series of steps before it could end up on formulary in our province and be available for our patients. Oh, sure. Brexpiprazole. Are the sites going to be in the available? Okay, so you'll get this. The second one is called cariprazine, Vraylar. It was approved last September in the US. As far as I know, it's not under review yet by Health Canada. But in the US, it's approved for treating bipolar mania and schizophrenia. Again, it's been studied and found effective for relapse prevention in, I believe, schizophrenia. I'm not sure about bipolar. But interestingly, there was a study that showed that it may have more effects on negative symptoms as well than the usual antipsychotic treatments that we have available now. I think there needs to be more research on that, but it does promote a bit of weight gain, as do a lot of our meds, unfortunately. 10% during a year, 10% of people had significant weight gain. It's not too bad compared to some of the other treatments we're using now. But as far as I know, it's not yet under review here. Iloperidone, I'll just mention it briefly. I don't think it's coming to the Canadian market. It's not that different from some existing antipsychotics, but It apparently has a less likelihood of causing a side effect called akathisia that some people are really bothered by. It's a kind of restlessness. And so I've actually had patients asking if they could have this treatment, but we can't get it, unfortunately. But another treatment that may be coming here, I hope, is called Invega Trinza, paliperidone, long-acting, but we already have a long-acting paliperidone called Invega Sustenna, which is a every 4-week injectable. And perhaps you're aware that for some people who don't like taking medicine, forget to take their medicine, too disorganized to remember to take their pills every day, we can use these injections that are given usually once a month, sometimes every 2 weeks, and that has been shown to reduce relapse rates. This treatment is the first one that can be given every 3 months. So, while it's not a treatment for, treatment-resistant illness, still it could be an option that could be helpful to some people who hate injections and who resist the idea of a monthly injection, but might be willing to get an injection, 4 times a year. So we'll see if it comes here. Now I'll talk about some medicines that are still in the research phase. There's this one that doesn't even have a kind of a name yet. It's being called ITI-007. Yeah, sounds like the name of a movie or something. But it's kind of interesting because, most of these drugs have more effect on the brain chemical called dopamine. And when you block dopamine in the brain, we don't have treatments that block dopamine just in the part of the brain we're most interested in, the part where you get hallucinations and delusions and all that. They also block dopamine in the part of the brain that controls movement. So that's why you get the stiffness and the drooling and the slowed movements and all of that, which are kind of stigmatizing, right? You can sometimes tell just by observing somebody walk across the room that they're on an antipsychotic. So this treatment has stronger serotonin than dopamine. It seems to have a very favorable side effect profile in terms of not causing those movement side effects, in terms of not causing a lot of weight gain, et cetera. It's had 2 successful phase 3 trials. So, as an aside, there are typically 4 phases in drug development. Phase 1 is kind of the test tube or animal research. Phase 2 is trying it in humans, generally healthy humans who are not affected by the illness, just to see how it's metabolized, make sure it doesn't cause any severe effects that were unforeseen. And then phase 3 is when you start testing it in groups of people affected by the illness you're targeting. It probably needs some additional studies before it will be submitted to the regulatory agencies. But it seems like it could have a broad action on psychosis as well as mood disorders, maybe dementia and autism too. Next, enicline. So this is a treatment that's supposed to be helpful for the cognitive impairments that Dr. Fredrickson talked about. The U.S. National Institutes of Mental Health, about, a dozen years ago or more, undertook this project to try to encourage the pharmaceutical industry to come up with treatments for the cognitive impairments in schizophrenia and mental disorders. And, they had a...
The conference is scheduled to end in 2 minutes.
Okay. Not true, right? Okay. Do we have people participating remotely?
No, that's
okay.
totally different thing.
All right. Well, anyway, So they had a big budget. You know, the NIMH is usually has good budgets for the projects they undertake. They came up with a standardized approach to assessing cognitive impairments, which, you know, has been very useful in research. And there are some treatments that are starting to make their way through the pipeline for cognitive impairment. A lot of them seem to act on the nicotinic receptors. So nicotinic, i.e. nicotine. Why do people with schizophrenia smoke? I think that came up in the previous session. Part of the reason might be because nicotine is a cognitive enhancer. It makes your mind a little bit sharper, you know, whether you have a mental illness or not. And, you know, that's been shown in testing. So enicline acts on these receptors, but, you know, you don't have to smoke it or take in all the toxins that you take in when you smoke tobacco. So it's undergoing phase 3 trials for schizophrenia as well as Alzheimer's dementia. But I understand that there were some severe gastrointestinal side effects in some of the dementia patients. So I'm not sure it's going to go forward for that indication.
Now over. Goodbye.
Okay. Everyone heard that voice, right? Okay. So anyway, yeah, we'll see how far this goes, and at least whether it ends up with an approval for schizophrenia, if not dementia. And then there's sodium benzoate. You've heard of this before because if you read a list of ingredients on a food package, you're likely to see this. It's used widely as a food preservative, but it has this other property. It affects an enzyme in the brain called D-amino acid oxidase, which breaks down certain amino acids that are used as neurotransmitters. And it was found in a study to have beneficial effects for both cognitive, negative, and positive symptoms in schizophrenia. The dose is big, 1 gram a day, but apparently it was quite well tolerated. So all of these things are in phase 3 trials now in various places. The thing about sodium benzoate is that of course, it's not patentable. I mean, I don't know, some pharmaceutical company may figure out how to, you know, alter it slightly so they can patent it. But with some of these treatments, if they're not patentable, then drug companies have no, you know, impetus to invest in it. So that's why it's very important that we have funding for public agencies to spur on drug development. Like, you know, NIMH and Health Canada, which is a much smaller player in all this. Now I'm going to talk about some medicines that are actually currently on the market or are known for various uses, but are not right now known as treatments for mental disorders. But research has shown that they may be effective in certain conditions. So the first one is undergoing research for cannabis use disorder. In other words, marijuana addiction in people with schizophrenia. So dronabinol is a synthetic form of THC, the active ingredient in marijuana, one of the active ingredients. And it goes under the trade name of Marinol. It's already been approved for treatment of nausea and as an appetite stimulant in people who have advanced AIDS or cancer. Now, clonidine is a different medicine that's been used to treat hypertension, but has also been found to be effective in ADHD and in opioid factor. If you use it before the age of 16, it increases the risk of schizophrenia. And if you keep using it, it makes your disorder worse. So we need treatments for this problem. So we'll see where this goes. Then there's aspirin. Everybody knows about aspirin. It's an anti-inflammatory. It helps with minor pain, fever. And the idea behind aspirin goes back a long ways because there's been this theory that schizophrenia is actually an inflammatory disease of the brain. So something happens at some point. There's inflammation in the brain that leads to neuronal damage and shrinkage of the brain because, there is evidence that people with schizophrenia or schizoaffective or even bipolar disorder, we know, have slightly smaller brain volumes. So if it's an inflammatory disease, or if at least some subtypes of these mental disorders have an inflammatory component, then can we treat that? And there is evidence that in young people, giving aspirin or anti-inflammatories might help. It requires a high dose, like 1,000 milligrams a day of aspirin. But if you give that much aspirin, you have to protect the stomach because aspirin irritates the stomach. It can lead to GI bleeding sometimes. But I've used this in a few patients, I think with a little bit of improvement. Anyway, it's undergoing phase 3 trials as an add-on. So the people are already on an antipsychotic, and then you give them this aspirin on top of that. We monitor this blood test called the C-reactive protein, which reflects inflammation somewhere in the body. It's nonspecific. It could be elevated because of anything from a toothache, to pneumonia. But we do find in some of our patients it's increased, and there's no other explanation for it. Okay, then there's cannabidiol. So THC, we already talked about. It's the ingredient in marijuana that gets you high, that might make you a little psychotic sometimes. So that's the evil twin to cannabidiol. Cannabidiol, it might be actually antipsychotic. And it's also present in varying amounts depending upon the strain. And there are two main strains or species. There's cannabis indica and there's cannabis sativa. And you can go into one of these dispensaries on Broadway or wherever, and the clerk there will be happy to talk to you about, the different varieties they have and how much THC, how much cannabidiol are in these different varieties. And sativa may have, in general, more cannabidiol than THC. And you can actually order a strain, I understand, from, I think it's grown in Manitoba, which essentially has no THC and mostly cannabidiol. So why do we care about this? Because the cannabidiol may have antipsychotic properties. At least it's not propsychotic. So could it either be a treatment or at least a harm reduction approach for people who like to use marijuana? On the clinical trials registry site run by the National Institutes of Health called clinicaltrials.gov, there are 8 studies listed as attempting to study cannabidiol in mental illness. So that's pretty interesting. This picture was taken in Brazil. I was there in 2014, and I met this team of researchers. The doctor on the right is Dr. Jaime Halleck, and he and his team did the first trial of using this drug called sodium nitroprusside in acute schizophrenia. Sodium nitroprusside is one of the most unlikely treatments you could imagine for schizophrenia because it has been a treatment for severe hypertension and heart failure. And it's given intravenously, usually in people who are very sick in an intensive care unit. So why on earth would you give it to someone with schizophrenia? Well, its mechanism of action involves increasing this little molecule that's very important in our physiology called nitrous oxide. It's a small molecule. It lasts a very brief time when it's generated, but it has powerful effects. It affects the cardiovascular system, obviously, but it also has effects in the brain on a very complex receptor neurotransmitter system called the glutamate receptor. And I'm going to talk a little bit more about this later. And there have been efforts, over the last decades to target this system because we know that the glutamate system is involved in psychosis and schizophrenia. For instance, everybody's heard about PCP, phencyclidine, angel dust. It used to be a common street drug, especially back in the 90s. It's not too popular anymore, but it actually is a model for psychosis, maybe even better than amphetamines. People with PCP intoxication show positive symptoms of psychosis. They also show some negative symptoms. So it's an interesting model, and it's been used in animal studies as well. So the effects of PCP in animals is used as a model to test antipsychotic drugs. And Dr. Serdar Dursun, who is a psychiatrist and pharmacologist now at Edmonton, actually did the first studies in animals of sodium nitroprusside to reverse PCP-induced behavior changes in animals. So that's how this all came about. And then, because it's easier to do studies like this sometimes in places like Brazil, this study was done ethically, but the barriers are a bit lower there than the barriers we face in doing studies like this. So they did the first trial. It was published in a very reputable medical journal, JAMA Psychiatry. And so when I was visiting, I saw this patient actually get the treatment. And she and her mother were there. And the treatment has effects within hours. And I actually saw this. I went in soon after the treatment got underway, and I went back a number of hours later. And she was more interactive. At first she seemed a bit suspicious of me. I mean, obviously I was a stranger, so this is an anecdote, but nonetheless, I thought I saw changes in her that did occur over hours, and that's what the study they published seemed to show on both positive and negative symptoms. So now there are trials underway in the US and UK on this. We've talked about getting a trial underway here. As I said, the barriers are kind of high because, for instance, in Vancouver Coastal Health, you're only allowed to use this drug in the intensive care unit. They're not using it in an intensive care unit in Brazil. They're using the lowest possible dose, and it seems to have very minimal effects on heart rate and blood pressure. All right, so some other medications that are available right now that might be useful, and that actually we've tried a few of these in some of our patients. Famotidine, or pepcid, you buy this over the counter for indigestion. It is a histamine type 2 receptor antagonist. Anyway, it reduces acid secretion in the stomach, but at high doses, it crosses the blood-brain barrier and has effects on this particular receptor in the brain. And it's been used as an add-on treatment in treatment-resistant schizophrenia. So there's some additional trials underway to see if this, is borne out and if it could be a treatment option. It's very safe and well tolerated. Then there's oxytocin. So oxytocin is a hormone, known sometimes as the love hormone. It's involved in mother-infant bonding and in lactation. It's also called the milk letdown hormone. So it's also released in orgasm. So it's an interesting and important protein, hormone. Because it's a protein, you have to give it either intravenously or you can actually give it intranasally. So it's absorbed through the nose, the nasal mucosa. If you swallow it, the stomach degrades it, so you can't give it as a pill. It can also induce labor, and it goes under the trade name of Pitocin for that purpose. So because it has this effect on behavior, a pro-social effect, it's being considered for treatment of autism, but also for cognitive and negative symptoms, and maybe even it has some effect on positive symptoms in schizophrenia. So again, it would probably be in addition to antipsychotic, but it could add a new dimension to treatment. Okay, then raloxifene, which goes by the trade name of Evista, it affects estrogen molecules. So some of you may even be on it. It can help prevent osteoporosis. It may also be effective in breast cancer. It's been found in postmenopausal women, so women who are no longer menstruating, who are not of childbearing age, to improve positive and negative symptoms. Excuse me. Again, we've used this in a few of our patients. Whether it can be safely used in men as well is an open question, but there are some trials underway. So I think this is my last of the laundry list, but a few more. So tocopone, Tasmar, it's available now in Canada, like some of the others I've just mentioned, for Parkinson's disease. It is a little bit better than some of the agents that affect dopamine that are used in Parkinson's disease because it seems to affect dopamine more in the frontal lobes, and that is better for people with psychosis. In other words, it's not likely to make psychosis worse if it just affects dopamine in that region. So it is being looked at for negative and cognitive symptoms in schizophrenia. Then there's this one called exenatide. It's not for psychosis, but we know a lot of our clients and patients with this disorder have a problem with weight gain and diabetes. Even before they're ever diagnosed with schizophrenia, people who end up with this diagnosis have a higher risk of diabetes. And then we give them medicines that cause weight gain. And so it's a major problem. This treatment is approved for type 2 diabetes, but it may also be helpful with antipsychotic-induced weight gain. So it's in a phase 3 trial now for that. And then ondansetron. Ondansetron is approved right now for nausea and vomiting. It's often used in chemotherapy patients who have severe nausea and vomiting. But it affects serotonin, and it may be helpful in negative symptoms. So it's being looked at for that. So, maybe some of these treatments will be approved. Maybe some of them will be helpful to, people who are afflicted by severe mental illness. I hope so. But we can't ignore other changes that people need to make in their lives in order to get better and to protect their brain function. Avoiding street drugs, of course, avoiding tobacco, eating well, exercising. People with severe mental illness often have a deficit of healthy fats, omega-3 fatty acids. So it's important to make sure that you get enough of those, but if you eat a fast food diet, you're not getting those. And you're not getting a number of other important things in your diet. And we know that exercise helps stimulate neuronal growth and renewal in the brain. And we've done some studies at UBC Hospital on this in people with schizophrenia. It increases blood flow and the volume of the hippocampus. The hippocampus is the organ in the brain. It's very important for learning and memory. All of us should do these things, but it's even more important if you have a severe mental illness. But the problem is, if you have one of these illnesses, often you don't have the motivation. You don't have the, your motivation is lacking, and also your ability to get pleasure out of the usual things is lacking. And so you need even higher levels of stimulation. So you look to drugs and high doses of caffeine and nicotine. So that's the challenge that we face. Caregivers, family members, et cetera, to try to steer everybody in a better direction than what seems natural for them because of their illness, unfortunately. So there are no, as Dr. Fredrickson said, there are no easy answers to this, but no matter what medicines we give them, all these things are crucial too. So I think I'll stop there and take some questions.
Hi. I found it very interesting, and especially with all the medications that are being tried as add-ons. With treatment-resistant schizophrenia, I'm just wondering, how do these individuals present themselves in terms of, I assume they're not 100% symptomatic or 90% symptomatic, or are they, as far as positive symptoms?
Well, I mean, they usually do have, I'm not sure what you mean by 100 versus 90, but I mean, they do have a lot of positive symptoms. Since we don't have good treatments for negative symptoms, it's really based on the severity of the positive.
That mathematical measurement is something that the Canada Revenue Agency uses as far as determining whether or not someone's eligible for the disability tax credit.
Mm-hmm.
So then my second question is it even measurable? Or is it, it's just a moot point? In terms of if a doctor is looking at someone, whether or not they might be eligible.
If they might be eligible, for instance, to take Clozapine?
No, for the tax credit.
Oh, okay.
The government likes these mathematical.
Well, yeah, I'm familiar with that. Not in all the detail you are, because obviously you actually have to submit those forms. But positive symptoms are measurable, and I think we as a profession need to do a better job in documenting that. We do in our program use a scale called the PANS, the Positive and Negative Syndrome Scale, that gives a number for the severity of positive and negative symptoms. There's another one called the Brief Psychiatric Rating Scale that's a little bit quicker, and it's been used in a lot of clinical trials. So yes, it can be quantified, most doctors, or clinicians in standard practice, though, are not doing scales like that.
Thank you.
Our son is on olanzapine and has terrible weight gain because of that, loves fast food, so is not getting the good diet. Is there any good replacement for olanzapine for someone like that?
Well, obviously I can't diagnose your son. However, in general, olanzapine, in terms of its effect for, severe positive symptoms, is probably a little bit better than some of the other antipsychotics, although not as effective as Clozapine. So there are some people who do respond well to olanzapine, and they may require it. So then we're stuck with the situation of trying to manage the side effects. And, the lifestyle changes are going to play a role in that, but there are some other treatments, such as a medicine called metformin, which is a diabetes medicine. It's been shown in a number of clinical trials to reduce weight gain in people who are taking antipsychotics. So that might be an option. Getting somebody on a better diet, that's just an ongoing struggle. And, if they can eat one healthy meal a day, if they can eat, 3 or 4 servings of fresh fruits and vegetables a day, even if they're going to go to McDonald's later, you're going to have to look for small incremental changes. Maybe give them a fish oil supplement if they don't want to eat fresh seafood or whatever. A fish oil supplement, it could be considered.
Hello. I was interested in all the different substances that are being
Hi,
tested.
David.
That are being tested, some that have been existing for a long time and some new ones. I know that there has been some other substances that have been banned from research for a long time, and I'm thinking of LSD and wondering whether there's anything going on with that and whether there's that shows any promise for any sort of help or support for people.
Yeah, there is some interesting research going on with, hallucinogenic type drugs or drugs that are, ordinarily not considered therapeutic, but not for psychosis. I don't think there's any likelihood that those drugs would help psychosis. I guess one thing I'd mention, I'm aware of, is that for post-traumatic stress disorder, especially PTSD that doesn't get better with the kind of usual approaches, MDMA, ecstasy, whatever you want to call it, has been used in well-conducted clinical trials to facilitate psychotherapy and has been found to have beneficial effects. I saw a presentation about this at the American Psychiatric Association meeting. Was it last year? So there is some research that's going on with some of these drugs, and some of them may have some therapeutic applications.
Hello. This isn't a question about pharmacology, but I wondered if you could speak to it. A few months ago, there was a report by CBC from Harvard University about a cluster of genes that were identified in the pruning of
Right.
the neuron process. I just wondered if you could explain that, or if there's any implications for therapy in the future you see coming from that research.
Right. So that was an important study, and psychiatric genetics is a rapidly evolving field. It's complex. I can't pretend to have a full grasp of it, but so that study looked at a particular gene related to a protein called C4. C stands for complement. And the complement proteins, it's a whole family of proteins that are involved in the immune system. But our physiology is, kind of conservative in that we make various proteins, but we put them to different uses. And the complement proteins, some of them, are used not just for immune function, but also as sort of, for neurodevelopment. In other words, the complement proteins are also involved in how neurons grow and connect and create a network. So in this genetic study, they found that a particular problem with that, the gene that codes for the C4 protein, predicts schizophrenia in a much more kind of robust way than any other genetic studies that have been done. And it probably doesn't explain all of schizophrenia, but it seems like it could explain significant subpopulation of people who have this disorder. And so it's not exactly proven how this all is connected yet, but the idea, I guess, would be that if you don't have appropriate C4 levels in the brain, then the neurons aren't able to make the right connections, and so and C4 becomes more active during adolescence, and so during that critical time when neurons are making connections as well as pruning back connections, not having functional C4 causes major problems, which can lead to the onset of psychosis. That's my understanding of it. And as far as treatment implications, I don't think we're there yet.
Okay, thank you. That was an excellent talk, and we certainly need more and better drugs. So my son probably falls into your treatment resistant because of sedation on Clozapine, and he's on lorazepam latuda, with good effect and also some side effects. But it's a drug that is not approved in BC or covered by BC Pharmacare. And I'm wondering if you have observed that we have problems with our provincial coverage for psychiatric medications, because I'm aware that this particular medication is covered everywhere else in Canada. That's my question.
Yeah,
You do reviews for the BC Pharmacare and whatnot. Of
well,
course, if people can't pay for the medication,
right.
they won't be getting it. They'll be getting maybe ECT, which might not be less expensive.
So, you know, the way that the drug coverage is approved is complex. I've been involved in it to some extent at the BC level. The government tries to get input from various parties to decide on drug coverage. Whether that process is adequate or not, I'm sure is open to a lot of debate. But, you know, I think that something to remember is that if a doctor thinks a patient really needs something, that there are ways to advocate for that, and there are exceptions that can be made. So if the right, you know, if a letter is sent and gives good justification for a particular treatment, it can often be approved despite the official policy.
I agree, and I know that's the case, although it is taking an awful long time, and it's very onerous on a short supply of psychiatrists, and it's just
Yeah.
maybe a step that's not necessary given the paucity of good medications. There just needs to be more choices, and they shouldn't be so difficult to access.
Well, I agree.
But it is a role for our organization.
That's right.
Supporting
Yeah, and you know, like the brexpiprazole and the other one I mentioned, I hope they'll be available in Canada soon, and you know, you can bring this up at the appropriate levels.
one of our organizations to do some advocacy, and they felt this was too political an initiative to get involved in. So, again, I think it raises the question whether our advocacy organizations for accept.
Thank you very much, Dr. White.
Thank you.